So we're going to go right by the objectives. You guys know we're trying to figure this out. So the first case is kind of the less typical. Second case is a little bit more typical. 31-year-old, fast-paced life, prosecuting attorney. He's self-referred. He's got symptoms of fatigue, more general symptoms of low T potentially, then some more specific symptoms like decreased libido, erectile dysfunction. And then he's got additionally some loss in his fitness overall. He's got a paunch developing over time, decreased cognition. His PCP said that he's got low T, and he wanted him to basically start injections right off the bat, this is actually, for those of us in practice, is a really common scenario that I would have walk into my office, actually. And wife, thank goodness, cooler heads prevailed. I want a second opinion. So here he comes. No allergies. The rest of the past med history is really non-contributory. No meds, no supplements. You know this is someone who's not been to a functionalist. And family history adopted, so it's kind of an unknown. The social history, he's married, he has no kids, possibly at 31 in the future, doesn't smoke, doesn't drink. He's actually pretty healthy as far as he's eating avocados and wild-caught grass-fed things and avoiding dairy and gluten. So even though he hasn't come and darkened one of our doors, maybe he learned this on a YouTube, I don't know. But he's got some good lifestyle practices going on. I laughed when I saw this. I think it said, yeah, he has no gut issues, but let's see. Oh, it's the next one, sorry. So this guy actually has no gut issues, and he's having 2 BMs a day, which is pretty much what I want to see. He does have some issues with sleeping, both initiation and maintenance. He's getting about 6 hours. And he wakes up at 4 o'clock to exercise. I mean, this is kind of that typical, if you're talking about Ayurvedic doshas, right? The hot-driven Pitta Vata people that just go, 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 dry, skinny. They've got, adrenal burnout. So it's not surprising that he's feeling this way. He's not snoring. He does have a lot of thoughts. He can't turn his brain off at night. So on exam, he's fidgety. He's yawning because he's missed his Red Bull and hasn't had it yet, maybe. He's getting up at 4 to train. He does 2 marathons a year, and he's doing these halves and things like that. So he's a really driven person, but he's doing these ultra cardio exercises. So already he's got maybe some extra oxidative stress. He might be a little bit more catabolic with a higher cortisol to T ratio. Talked about a little bit yesterday. His BMI is 23, so I would suspect that that's right. Thinking about the very few people I have that show up with a BMI of 23, they get discriminated against, right? We look at them and say, why are you here? You look very healthy. And if there's nothing else you guys have learned this last few days, that is not always true. The rest of his physical exam is for the most part, non-contributory. His labs initially, pre-treatment, this is a Clomid consideration because of his age and desiring fertility. Normal CBC, so we're okay on the crit as far as things there. Chemistry's great. He doesn't have any problems other than, I would call that an abnormal or impaired fasting glucose. I can't necessarily say it's insulin resistance by typical criteria, but even a 6, I'm thinking, okay, that's less than optimal. And the other thing that makes me even more concerned there is that triglyceride of 135. Yeah, it's less than 150, but I like my patients to be 75 to 100. LDL is fine, which often is the case. LDL-C is pretty worthless in people that have any leanings towards metabolic syndrome or insulin resistance. It's often, as we know in the Jupiter trial in 2008, not a problem even when there's inflammation in diabetes. A1C, 5.3, so again, pretty doggone good. He's not showing classic insulin resistance by that particularly, and he's not got a lot of inflammation. HDL, not bad for a guy, it's okay. Here's some more labs. Here comes the abnormals. So total T, really pretty low. You guys saw on an earlier slide today, erectile dysfunction starts even showing up there. He's got free T that's low as well. So both total serum and free are problematic. His estrogens also are suppressed, which makes sense. In a lot of these guys, they don't have any substrate to aromatize to estrogen, so it's low as well. DHT, kind of mid-normal range. DHES, he's got pretty okay. I mean, I'd like to see at his age maybe a little bit higher, but that's not terrible. So already from that last talk, what am I thinking? Well, he may not have problems with rheumatoid arthritis or autoimmunity inhibiting sulfation, because you've got that kind of a number. LH, 5, that's right in the middle of normal. These gonadotropins really are unimpressive. You could say that they're inappropriately normal, right? From the total T of 260, that's really low. That's not what I would think is a normal response. So already I'm thinking, this guy has more elements of maybe a central secondary issue than primary. Prolactin is normal, which I would expect. I don't usually see prolactinomas as the cause of inhibiting LH production and causing low T unless I've got total Ts in the 180 range, really low, and you rarely see that. Sex hormone binding globulin, not a player. It's kind of middle range. PSA is fine. So this is going to be a challenge seeing this. I think I'm going to have to look down here. So let's see. This is our Dutch stuff. And with this guy, yeah, pretty typical. You're seeing we're looking at the estrogens first. And he's got high estrogens here despite what we saw in the serum. The urine metabolites and estrogens are telling a different story. What are his metabolites? Let's look at the estrone. I don't really look at the estradiol side for the reasons that Mark mentioned as far as those ratios not coming into play. But yeah, he's got pretty good ratios there. He's got a lot of 4, however, and he's still got more of the 16 than I like to see than the 2. So let's go down, keeping in mind that the 4 is not a good thing there. Let's look at his methylation. His methylation is low because we don't really see that 2-to-1 ratio happening per se. So this is a guy who I'm really concerned about that 4-hydroxy, that 1B1 pathway. What is going on here? Is this somebody that you worry about having that phenomena that I've talked to you about, high estrogen circulating, stimulating prolactin and the 1B1 pathway in those zones of the prostate? I'm really concerned about prostate here. So that's something to consider as well. Moving away from estrogens, what about his cortisol? We're trying to bring all of these axes together. He's got crazy CAR. I mean, he's got a real, more than 50 to 75% rate there, and it's elevated. So the fatigue that he complained about may be due to too much. We heard earlier how hypercortisol states can present with fatigue, just like hyperthyroid patients and Graves. One of the worst symptoms they get is fatigue. And everyone thinks, oh, yeah, no, that's hypothyroid. No, on either extreme with cortisol or thyroid, you can get fatigue. So his fatigue could be from too much. Doesn't certainly look like a hypocortisol situation. And it looks like his overall gland production is really revved up. We know he's not, we don't know that he's hyperthyroid or not. That would rev the metabolic machinery and lead us to the wrong conclusion. And he's not obese. So the two conditions where we see that 11 beta HSD change, we don't really know that we have that set up. So this is hopefully at face value, just an over-revved guy, stressed cortisol. Organic acid testing is super helpful. When you see low methylation, I want to know what's going on with things like MMA. If MMA is elevated on an organic acid test, you can think of problems with probably low B12, independent of what the serum B12 is, which is really kind of a rotten way to judge repleteness of B12. And then also things like B6. He's got an MMA that's above the normal range, so I'm thinking about maybe that methylation's a problem because of the B12. being a little bit low. And then he's also got an issue with his pyroglutamate there being a little above range, which can be a marker of problems with deficiency in glutathione. So what did we learn this morning about glutathione? You know, it's kind of the last-ditch effort to pull off those quinones and detox that really high 4-hydroxy metabolite. So this guy's in trouble with that 1-2 punch of the high 4 and really no glutathione to get rid of it before it becomes potentially an adduct disrupting DNA character. Okay, then marching on down, we have a little bit of a low-end melatonin representing that night before. Yeah, that might be why he's having trouble with his sleep initiation and maintenance. His oxidative stress markers, not too bad. Let's go into case 2, you guys. And this is a little different scenario. This is going to be kind of the other type of person that you see walk in. So going back to the big screen, 60 years of age. He's got decreased libido as well. He's gaining weight gradually over a couple years. He's feeling like he's aging prematurely. He's stressed out. He's been retired. This guy's PCP said he's got prediabetes, borderline hypertension, low T, and inflammation. And, you know, he's not really comfortable. So he boots this guy out of his practice and says, go find some rebel like Holthouse. So he shows up, he comes in, he's got history of some allergies there, which are pretty inconsequential to this case. He has some issues with his cardiometabolic and cardiovascular risks. He's overweight. There's no question about this guy. And yeah, he's this retired Wall Street dude. He's heavily engaged with not sleeping well and has now this kind of sad dietary deal. He's got his diet all kind of whacked, you know. So not a lot of good to say about his lifestyle on the bottom of the matrix there. The review of systems, yeah, now he's sleeping a little better than when he was working, but my gosh, 3 to 5 hours a night. I guess that's what Wall Street bankers do. Since retiring, he's at 5 to 6 hours of night. This guy does snore, and so he's got a normal sleep study, which is kind of interesting. By the way, just a teaching point, a normal sleep study doesn't always get you off the hook. Often, if I'm really suspicious, if they've got an elevated crit, things like that with not a lot of other reason for it, I'm going to do a nocturnal oximetry just to make sure they're okay. Some of these guys that are older that have these kinds of cardiac risk factors can have a little bit of undiagnosed CHF, and they can get hypoxic at night as well. So not all that causes hypoxia and an elevated crit is apnea. He, as far as gut issues, he really doesn't have any. However, this is what I was thinking I was referring to earlier. One bowel movement every other day. In my practice, that would definitely be a gut issue. I'm wanting 2 a day, at least once a day. So GU, nothing going on with lower urinary tract symptoms. He's recently had a nuclear stress test and an echo, which is nice and reassuring to some degree. He was told that everything looked okay. So on exam, other than having central obesity and kind of looking tired, pretty much unremarkable. BMI is at 31, so this guy's obese, and he's centrally obese with a waist over 40 inches for Caucasian. His BP, boy, that's not borderline in my book or anyone else's anymore, or really ever in the last few years. You know, there was a time JNC8, I think, was saying that if you were 60, you could allow it to go up to 150. So I'm guessing that case might have been made a couple years ago. But in 17, we had the hypertensive guidelines change, whether you believe them or not. Now 130 over 80 is considered first degree, step 1 blood pressure problems. And there's really no term as pre or borderline. It's elevated if it's above 120, essentially, to 129 on systolic. He's really irrelevant. He's got end organ damage. The guy has a retinopathy. He's got AV nicking, which we know is most commonly caused by systolic hypertension. So this is a guy who I don't care what's after your name. If you're not treating him with an antihypertensive, it's malpractice because he's got end organ damage. Whether it's kidney, whether it's something like this, you got to treat this while you're doing your functional magic. The remainder of the exams, not really contributing. This guy, again, no problems with his crit, looks okay. You know, marginal compromise on creatinine for a 60-year-old guy. I'd love to see a GFR or a cystatin C on him. I don't know that he's got good lean body mass, so it would matter. Neither of these cases had body comp data on it. I would have loved to have had, but he's got some issues for sure, as we heard early with fasting insulin, and this guy does have insulin resistance because his A1C is 5.7 and higher. He's got his suppressed adiponectin, which doesn't surprise me with his central adiposity. He's inflamed with a CRP that's high. And don't, by the way, wait for that to be elevated to suspect inflammation. It can lead you in the wrong path if you're using that lab to hang your hat on as to whether somebody's inflamed or not. That is one marker. And so you've got to look at fibrinogen, complement. There's all kinds of things that are secondary out of the liver that respond to TNF-alpha and IL-1 and IL-6. Cholesterol, yeah, total cholesterol is worthless as far as I'm concerned because it's not really helpful. I'm looking more at triglyceride and HDL ratio there, which is horrific. You know, that's at 6 or so. Again, LDL, it's neither here nor there with these pre-diabetic and diabetic patients. It's not always elevated. In fact, often it's not. If you do an LDL particle number, they're almost always elevated in this type of a cardiometabolic patient, regardless of LDL-C. That's the condition where you see a divergence in what LDL-C and particle numbers look like in those pre-diabetic and diabetic patients. So numbers, again, here comes the abnormal stuff on the endocrine side. His total T is low at 300. His free T is 35. You know, his SHPG is suppressed a little bit. Why? Maybe more than that other guy. He's got obesity. He's got insulin resistance. All those things suppress SHPG. So I'm not terribly surprised that his free T is a little higher relative to the total in this particular case from the skinny guy earlier. His estrogens are a little higher. They're in the estradiol is in the high normal range. I'd like to see him about 35 or less. But yeah, a guy that's got all this central obesity, he's aromatizing like mad. These are the guys, by the way, that you have to be really, really careful before you just jump to TRT because they aromatize like crazy. And he'll have a estradiol level of 60 if you're not careful to adjust and kind of pre-treat with some of the things we're going to talk about. PSA is normal, prolactin is normal, as are his gonadotropes. So his salivary free cortisol pattern, his CAR is kind of, it's kind of an anemic. I don't know that I'd call it flat, but it's not something that I'm too excited about. The biggest issue is that he's lost some of his normal pattern, and certainly at night, here's the reason why he's having trouble sleep. You can see that kicker right there before he tries to go to sleep. So looking again at the estrogens, now this guy, he's got estrones that are low, and he's got estradiols that are in the high side. If you continue on down to the metabolites, this guy's, crazy amounts of 2-hydroxy. He's got kind of normalish looking 16 relative to that, and his 4-hydroxy's, not a big deal. Again, he's a poor methylator. In this kind of a case, I see patients like this all the time that I inherit. Boom, they're on DIM. They're on, excess cruciferous veggies. They're on rosemary. They're on indole 3-carbinol. With that kind of a 2-hydroxy, I would suggest you don't do that. Overdriving that is not necessarily a healthy objective. It's all about the ratios. So again, with this guy, you're going to want to focus more on methylation, glutathione support, and long before you do anything with testosterone replacement therapy, you're going to work on these guys with their cortisol, you're going to get their aromatase calmed down with that list of things that you've now learned to naturally inhibit aromatase with. The biggies are getting rid of this guy's prediabetes, his obesity. The first guy wasn't drinking alcohol. I didn't say on this one, but I think he was a drinker. Wall Street banker, probably. I'm just going to guess. Anyway, his alcohol content could be a factor. Certainly his age in this second case is a factor on kicking up his aromatase and his central obesity. So you're going to work on the cortisol. You're going to look at emotional freedom techniques, tapping. You're going to look at anti-hopper stuff with limbic rehabilitation. If you don't know about that, come ask me about it. You're going to look at Stephen Porges' book on polyvagal theory, where he talks about the ventral and dorsal vagal distributions and the divisions, activating the healing power of the vagus nerve. That's a Stan Rosenberg book. I don't care if you read the book, just look at the activities in the back, have the patients do them. Amazing at helping bring down cortisol, which we know is a problem with aromatase. So you guys have all the information now. You just need to bring it all together in patients like this that are real. So you have to kind of work the matrix, as we say at IFM, before putting this guy on TRT. Could I use clomiphene on this guy? You could try. Often by the time they're in their 60s, they're less responsive because the number of Leydig cells and the sensitivity of the Leydig cells to stimulation from either LH analogs like HCG or excess FSH and LH from the SERM, Clomid, are less effective. I always start there, especially in somebody like this. I'd be really afraid to put this guy on testosterone until I fix that excess estrogen. So I'm going to try to fix by upregulating that one. In his case, he's got plenty in the first one of 2-hydroxy. The issue is that 4-hydroxy. So you're going to want to find out, is this guy inhaling diesel fumes and exhaust or exposed to some kind of toxins that's upregulating his 1B1 pathway or what? So you're looking at that kind of a thing or upregulating the good guys. Other things you can glean from this second case, looking at the androgens, Mark kind of just went over this. You can see from the DHEA metabolites, this would show that he's got 5-alpha heavy, but when you look at the testosterone side of things, I'm not so sure. His 5-alpha androstenediol down there below DHT is pretty moderate. So again, don't fall into the trap of treating these dials. You got to look at the patient in front of you and see what makes sense. And when there's things that don't agree, I think it's important. The take home here is that he's got really low serum, and it's reflected also in his urine metabolites. So what did I do for these guys? I wrote it down because there was a lot. So case one was this gentleman that was kind of skinny and stressed out and had low T, normal BMI. Basically, I wanted an in-body on him because I wanted to see, if you noticed in the history, it said he was svelte looking and a BMI of 23, but he was soft. He was soft looking. To me, that means maybe low lean muscle mass. So I'd want an in-body. His cortisol, he was all arranged, so you're going to use those cortisol suppressing new techniques that you all learned from our doc first thing this afternoon. And you're going to do these limbic and vagal things. Aromatase is a big deal. Again, get rid of stress, inflammation, insulin resistance. Don't forget about MBSR, mindfulness-based stress reduction, 8-week curriculum. Find someone in your area that does it. It's amazing. They come back like new people, empowered. MBSR, mindfulness-based stress reduction. Yeah. Can be super helpful for taming these guys as far as cortisol. Think of natural aromatase inhibitions on case 2. Zinc deficiency is a huge problem with aromatase, gone awry, gone off the rails. Green tea catechins extract, we've all mentioned vitamin C is helpful at inhibiting aromatase as well as resveratrol. flax, lignans, and soy isoflavones. And don't forget about the sleep. Both these guys had crappy sleep. And if you learn nothing more from the first lecture, the first day from the doc, man, hit those easy targets. Stress management, good food, and healthy 8 hours of restorative sleep. And it really has a huge impact on the HPA, HPT, and HPG axes.